The effects the Affordable Care Act will have on healthcare access, cost, and quality. Presented by Group 7, Latoya Davis, Elizabeth Washbrooks, Nancy Mortsey, and Jeremiah Boker. We have the finest healthcare system in the world. That is what this healthcare law will destroy, claimed Senator Ron Johnson. While Representative Nancy Pelosi said, a healthier life, the liberty to pursue happiness free of the constraints that the lack of health care might provide to families. Under the Affordable Care Act, you have that ability, that liberty to pursue your happiness. Despite being passed in 2010, the debate over the Affordable Care Act, or ACA, is still very active. In order to determine whether the ACA is a good or bad law, we must look at major factors it has had an effect on. These factors include who has gained medical coverage since the implementation and how it was possible, the exchanges and how individual states are handling them, the changes to Medicaid, the changes to health insurance premiums, and the political issues on both state and national levels. What is the ACA? The ACA is made of two separate acts, the Patient Protection and Affordable Care Act and the Health Care and Education Reconciliation Act of 2010. Combined, these two acts increase the number of citizens with medical health insurance and makes positive changes to Medicaid and the Children's Health Insurance Program, or CHIP. The ACA's main objectives are to increase healthcare access, increase health quality, and reduce medical costs. Who are the newly covered? Since being made law in 2010, 28.2 million people have benefited from the provisions. Of them, 11.7 million people have purchased insurance policies through the exchanges, 10.8 million people gained medical coverage through the expansion of Medicaid and CHIP, 5.7 million people under the age of 26 were able to maintain insurance coverage by being allowed to stay on their parents' policies, and many more were able to obtain employer-sponsored health plans. The largest population of the newly covered are in their 30s and are in good health, but the expansion allowed by the Act has also reached people who have often been uninsured, coming from poor backgrounds and having less education. The Act also reaches those who were previously uninsurable due to pre-existing conditions by making it illegal to use that reason or care-acquired conditions to deny a policy. How is this new coverage possible? The increase in citizens carrying medical insurance was achieved by creating individual mandates, employer mandates, expanding Medicaid, and providing federal subsidies. The individual mandates require that all citizens have health insurance or pay a penalty for not. The employee mandates requires that employers with 50 to 199 full-time employees to either provide a health insurance plan or pay a penalty per employee. And employers with more than 200 full-time employees must provide the health insurance plan, but does not have the option to pay the penalty. The expansion to Medicaid was done by changing eligibility requirements, specifically the maximum income levels. In 2014, the income limit for Medicaid eligibility increased to include those with an income of up to 133% of the national poverty level. Federal subsidies have also contributed to the increased enrollment of healthcare coverage. Federal and state governments have been providing subsidies through the tax systems for healthcare for some time now. Mainly, the subsidies were offered to those covered with employer-sponsored plans, but also included self-employed workers with high medical expenses. The ACA now allows tax credits or subsidies to benefit low and moderate income families. These subsidies decrease the premiums families would have to pay to maintain medical insurance coverage. and even applies to those purchased through the exchanges that were created by the ACA. What are the exchanges? The ACA states that the expansion of healthcare coverage should occur by introducing state-level insurance exchanges. However, that was declared illegal by the Supreme Court on June 28, 2012. Healthcare exchanges are ran by non-profit groups or government agencies that organize and manage a private market for purchasing medical insurance. These exchanges provide small business and individuals a selection of certified health plans that meet the requirements of the new law. The state exchanges offers those seeking health plans 4 levels of coverage, which requires different percentages of medical costs to be paid by the insured. The levels provided are the Bronze Plan, which pays 60% of healthcare costs, the Silver Plan, which pays 70%, the Gold that pays 80%, and the Platinum, which pays 90%, all minus deductibles and co-payments. Comparatively, insurance provided through the employment usually covers 85%, which falls between the Gold and Platinum plans offered in the exchange. How are the states approaching them? The success of the ACA greatly depends on how the states will respond to the changes. This has been a challenge since the states have a history of pushing back, as seen in the 2012 Supreme Court case where 26 states jointly filed a lawsuit. Politics has played a large part in how the individual states have responded to the exchanges. States that are led by Republicans fear the exchange and the ACA in general, so they've refused to establish exchanges, while states led by Democrats allow the federal government to maintain and operate their exchanges. Other states have already created the exchanges under the state laws, and some states hesitated to create the exchanges, fearing it would prevent citizens from being able to choose their own preferred provider. Since 2013, all states have had exchanges, but who operates and manages the exchanges vary by states. 17 states have state-run exchanges. 7 states have state and federal partnerships to operate the exchanges, and 27 states have federally ran exchanges. There are 51 state exchanges because Utah has both a state-ran and a federal-ran exchange. How is Medicaid associated with the ACA? Since the ACA was enacted and the Medicaid program has undergone significant changes. One provision of the ACA is that Medicaid eligibility be widened so that more citizens would qualify. As mentioned before, the ACA increased the income level required to be eligible to 133% of the national poverty level. By widening the eligibility requirements of Medicaid, more people receive Medicaid benefits. The way Medicaid reimburses medical facilities and physicians has also changed by becoming value-based. Previously, the reimbursement had been based on a fee for service or volume, rather than the value of care given. The ACA also includes an information technology systems and data provision, which provides technical resources to ensure the Medicaid systems remain functional. The effects on healthcare insurance premiums. The premiums of policies purchased through the exchanges varies based on several factors, as do insurance policies purchased through other avenues. For example, in the exchange, a 27-year-old would pay $95, while a 50-year-old would pay $936 for the same plan. However, the cost won't vary based on the health status or gender of the person. All plans available for purchase through the exchange have lower premiums than plans purchased by employers, by an average of 1 to 27%, depending on the plan level. For example, an average age employee would have a premium of $6,119 with an employer-sponsored plan, while that same person would have a premium between $3,804 and $6,058 if the plan was purchased through the exchange. The change in premium for policies purchased outside the exchange as a result of the ACA is dependent on the state where the policy is held. In states that have expanded Medicaid, more policies are issued, so all premiums will decrease, including those purchased through the exchange. In states that have not expanded Medicaid, fewer policies are issued, causing all premiums to increase. In states that refuse to expand Medicaid eligibility, only half of those left uninsured, or 3 million people as the Congressional Budget Office estimated, will be able to purchase policies on their own while receiving federal subsidies. The remaining 3 million people who would be eligible if the state expanded the Medicaid coverage would have to purchase those policies without receiving subsidies. Political issues and implementation challenges. The ACA is a strongly debated topic, which has greatly divided the political parties. Currently, 76% of Democrats favor the law, while only 25% of Republicans and 42% of independents do. Despite the federal government offering to pay for the cost of Medicaid expansion, only half of the states have expanded their program. Concern over political sustainability and minimizing expenditures have also contributed to the delay in implementing the law. Political issues and its variables. The financial factor is a large issue in the debate over the ACA. Part of the reason only half the states have expanded their Medicaid program is out of fear that the high national debt would prevent the federal government from following through on its promise to help finance the expansion. The federal subsidy for private health insurance costs the government about $250 billion in lost tax revenue in 2013, and the new tax credits, which will be in addition to the private health insurance subsidies, is estimated to rise from $45 billion in 2014 to $146 billion in 2017 as more people enroll in coverage offered through the ACA. But many people with health care coverage that have had employer-based plans have already been receiving a subsidy for medical insurance through federal and state tax exclusions unknowingly. Those who disagree with the ACA worry that medical expenditures may increase. If new drugs are formulated, consumers start moving towards the anticipated genetic testing for personal medicine, and hospitals and physicians join together with insurance companies to expand their market power. But since the ACA has been implemented, the rate of those previously uninsured seeking services for preventative care has increased greatly. This increase is supportive of the ACA because failing to receive preventative care increases the chances of having worsened conditions which are more difficult and expensive to treat. Hospitals and medical facilities also appreciate the new coverage the ACA offers because even if they are reimbursed at lower rates, they receive something, which is more than nothing. Those against the ACA also fear that the quality of care will decrease. As Medicaid reimbursement rates decrease, while private insurance rates remain high, and the amount of care required increases with the age of population and the newly insured. But to ensure the quality of health care received in the United States remains level or increased, the ACA will use the Value-Based Purchasing Reimbursement Program, or VBP, to replace current methods of reimbursing medical facilities, focusing on volume and service provided rather than the value of the care given. Higher reimbursement rates will be paid to facilities and physicians who produce better patient outcomes, which ensures quality and uses better clinical practices, which reduces cost. Is the ACA a good or bad law? President Obama created a frame of what the reform should include, such as increasing eligibility for Medicaid coverage, requiring employers to offer and individuals to have insurance coverage, as well as adjusting Medicaid payments and introducing incentives to provide better health care delivery. But had Congress create a plan which allowed insight from state plans such as the Massachusetts plan, which is strikingly similar to Obamacare, resulting in a drawn-out, controversial, and complicated law. The Supreme Court's decision to allow states to choose not to expand Medicaid eligibility greatly hurt the ACA's success overall, because states refusing to do so causes the increased premiums, a financial burden to those who do not qualify for federal subsidies but would qualify with the expansion, as well as to hospitals and other medical facilities who must treat the patients who fall within that gap, and encourages private health plans to leave Medicaid and Medicare programs, while on the other hand, the increased coverage allows for more people to access medical care, while reducing the worry of losing their coverage, not being able to find reasonably cost health care, or not receiving quality care. The results of a law will never be perfect. It will have both positive and negative factors. Society as a whole will benefit from the ACA because it takes care of those who are unable to do so without federal assistance, such as those that are under 26 years old and with pre-existing conditions. This is crucial because 45,000 people die annually due to the lack of health insurance. But the economy will suffer as the national income decreases by more than $146 billion to provide the federal assistance. Regardless of how the law seems now, since the ACA will not be fully in effect until 2019, it is not possible to determine the success of the law overall at this time. The ACA is a very complex law that, while may have been based on good intentions for society, has created a large divide within the country. To determine whether the law was a good or bad law, the complicated task of weighing the positive and negative effects the law has had on the healthcare industry must be completed. These factors include who has gained coverage and what the effect will be on the society, how the newly covered citizens are covered, and how the exchanges work, how individual states' decisions towards the law influence how effective the law is, the changes made to Medicaid, the overall effect on insurance premiums, and what political factors play a part in favoring or disliking the law at both state and federal levels.